Evet, bu oturumun 4. konuşmacısı olarak ben sizlere...
As the last speaker of this session, I will be speaking about the neurobiology of the sleep in attention deficit hyperactivity disorder. What do we know in terms of neurobiology? I will try to summarize it. As we all know, the ADHD is the most common neurodevelopmental disorder. Prevalence in child and adolescent is 5%. And it has 2.5% in adults. And according to the Turkey prevalence, we see that the rates are higher, and this have an impact on the clinical practice of ours. What do we know? In the historical perspective, in 1902, for the first time, the ADHD condition has been published, and then it has been defined as the minimal brain damage, and then it has been defined as the minimal brain dysfunction. Indeed, the ADHD has penetrated into literature starting from 1970s, and the definition ranking system has been defined starting from 1970s. This is a disorder whose definition has been crystallized very recently. In the DSM-5, it has been defined as the neurodevelopmental disorder. So, what is the correlation of sleep with the ADHD? These kids are quite active. They have problems in the daytime, but sometimes they have huge challenges in the nighttime, and it has been mentioned in many of the publications in the literature. In the DSM-5, it has been stated that sleep disturbances will be eliminated from the diagnostic criteria, but we should always take the sleep disturbances into consideration, because this is a topic that has been studied quite extensively. But as you see here, the number of the studies increased. You can see the number of the studies and how much they increased. And you can see that in the first 6 months of this year, many of the studies have been conducted so far. Although this topic has been ignored, but the number of the studies are increasing on this topic. Generally, almost all of the studies are cross-sectional, and they are trying to understand the trajectory of the disturbance and the disorder. There are some subjective assessments and the objective assessments. And when we receive feedback from the families, of course, the biases might be present, both for the children and for the parents. And the objective assessment might be done with the polysomnography and the actiography. What I would like to underline here, the sleep and the ADHD and their correlations are bidirectional, and they are quite complex. Many of the studies are cross-sectional, as I have told you. In the prospective cohort study, it has been stated that this study was conducted in 1 year, and many of the children didn't have any sleep disturbances. Only in 9% of the children, 49% of the children, there are transient sleep problems, and 10% of them have permanent sleep disturbances. Of course, sleep phenotypes are present in the ADHD. We see that the sleep features are different from each other. There are 5 sleep phenotypes for ADHD. The first one is characterized mainly by a hypoarousal state. And there is a theory in the ADHD kids, there is a arousal problem, and there is an increase in the motor activity in order to cope with that problem. These kids are quite active, but the daytime sleepiness might be increased, and this has been shown in many of the studies consistently. The sleep latency increased during the transition from wakefulness to sleeping. The circadian rhythm should be on balance, and the hyperarousal might increase the sleep latency in the ADHD kids. Apart from that, there are some associated, breathing-related problems, and there are some related to RLS and periodic limb movements, and these are quite common in the ADHD. As it was mentioned by Mr. Shahin, when we use EEG, there is not an increase or decrease in the arousal, but although we cannot define it as an epileptic seizure, we see some EEG differences in the ADHD kids. ADHD is one of the most commonly observed problems in the clinics. The sleep disorders are commonly observed as well, but although it was mentioned in the clinic by 10%, in our clinical practice, the sleep problems emerge by 25 to 50%. What do we see? Bedtime resistance, sleep onset difficulties, night awakenings, difficulties with morning awakenings, sleep disordered breathings, and daytime sleepiness are among the problems, among the sleep disturbances that we have encountered through the feedbacks coming from the subjective family feedbacks. Objectively, the sleep latency increase, non-REM transition and REM transitions are higher. They are shorter, but the transition from non-REM to REM is faster. Apnea, hypopnea index is higher, and the sleep efficiency is low in this group, and true sleep time is reduced according to the actigraphy results. And this is a review of meta-analysis studies results. Okay, there are some sleep disturbances. Behavioral insomnia, circadian rhythmic dysfunctions, and the restless leg syndrome and the periodic limb movement disorders or respiratory related sleep disorders are commonly observed in the ADHD. When we take a closer look to the ADHD and the neuroanatomic standpoints, you will see that locus coeruleus is quite important, and thalamus is important in terms of the working memory and the behavioral inhibition in the ADHD, and it is also important for the non-REM regulation in the sleep. In the ADHD kids, there are some parts which are activated during the tasks, and there are many overlapping points with the normal REM sleep and the task performance. REM neurotransmitters have been mentioned in the previous 3 studies, but the bold ones in these presentations are showing us the ADHD related neurotransmitters. There are many hypotheses which are defining the ADHD and sleep problems. One of them is the behavioral model, oppositional defined problems, and the mood disorders, emotional disorders, and difficulties might indeed contribute to the sleep disturbances as well on the subjective assessments. Circadian model is another model. Mr. Halil already mentioned it. The increase in the need for the sleep and the loss of balance here matters. The delayed increase in endogenous melatonin levels is contributing to the increase of sleep latency. One of the other important aspects here is the locus coeruleus. These dysfunctions in here for transition to the sleep, and it has some difficulties for the executive functions as well. Another model is the genetic model, and this is a new model. We don't have the clear-cut evidences for this model, but as I have already mentioned, in the COMT genes, when we see single nucleotide polymorphism, it might have changes in the dopamine inactivation enzyme, and this can lead to ADHD and sleep continuity, and also has an impact on the working memory and the executive functions. The clock is another polymorphism on the gene. This is showing us the differences between the morning people and the evening people. Of course, this is a new study area, and since they are polymorphism studies, it should be evaluated in detail. I have already said that I will focus on the neurochemical model. These neurotransmitters are stimulating the wakefulness, and they are having problems in different parts of the ADHD brain, and acetylcholine is quite important for the REM. When you take a look to the ADHD and the neurotransmitters, you will see that this slide is self-explaining. Serotonin is a melatonin predecessor, and it might have some melatonin deficit, and the noradrenaline deficit in the ALC and monoamine acetylcholine ratio might be affected. In the dopamine mesolimbic pathway, whenever there is a problem, then we might have REM sleep alterations, and in the nigrostriatal pathways, the leg restlessness and periodic extremity movement disorders might be the result. Of course, melatonin is quite important for the sleep latency, and it is also important for the problems that are emerging from transition to the REM sleep. Before I finish my presentation, I would like to underline the importance of the correlation between the drugs and the sleep. Psychostimulants, non-stimulants, bupropion, TCA, and alpha agonists modafinil are used. In our clinical practice, we receive many feedbacks that stimulants have sleep disturbances. They have been said that it delays the sleep onset, night awakenings, shorter sleep duration, and insomnias. But the rebound effect is the thing that I would like to underline here. When in the rebound effect, there is an increase in the ADHD symptoms, and the severity of those symptoms are increasing. And we don't know whether this problem is emerging from the rebound effect or not, and we have to make a differentiation in that regard. In some of the studies, we know that we are using some short-acting agents, but low dosages in the nighttime and short-acting methylphenidate might be another option. There has been many studies. As I have told you, I try to summarize what we have known and what we don't know about this problem. Sleep is a topic that has been ignored, and as we see in the other presentation, the brain is quite complex when it comes to wakefulness and the sleepiness. That's why in the ADHD, neuroanatomic structures and the genes are coming into play in terms of the sleep disturbances and the visibility of the ADHD symptoms. The relationship between the ADHD and the sleep is quite complex, and in our clinical practice we shouldn't ignore it. At the end of my presentation, what I would like to underline here, ADHD is a 24-hour disease. It is present both in daytime and also in the nighttime. We shouldn't forget that. Other than that, evaluating the sleep problems will have a huge impact on the quality of life. Thank you very much for your patience.